I'm just going to take off the transcription because it's transcribing and recording. And you can still see my screen?
Yes.
Yes. Yep.
Okay, so I can't see you guys now because I'm presenting. So welcome everybody. I'm very excited to be here today to present to you not really an update, but just kind of bring us back. Anybody that's not talking, please mute because I'm hearing a lot of background.
Right.
Thank you. So I want to share with you a little bit about where we're going post-pandemic. I'm still hearing a lot of background. There we go. Perfect. Thank you. So I'm very happy to present to you today on where our team is going with some of our new initiatives and things that we're working on, and just share with you, kind of bring us back full circle not post-pandemic, but from the last 2 years and everything we've been through with floods and wildfires, and explain to you the why, because we're hearing from operations that some of you are maybe asking, why all these changes, why all these initiatives? So I just want to kind of bring us back full circle with that. So I will begin this presentation with an acknowledgement that we recognize and acknowledge that we are collectively gathered on the traditional, ancestral, and unceded territories of the 7 Interior Region First Nations. This region is also home to 15 chartered Métis communities. It is with humility that we continue to strengthen our relationships with the First Nations, Métis, and Inuit peoples across the interior. Today, I am calling in from the Silix First Nations in beautiful Penticton, where it is sunny and very warm, for which I am very grateful for. I thought I would start and just share a little bit about me. My name is Susan Labonte, and I have my colleague Brandy Antle on the call as well. I'm sure you know Brandy. So I am the Regional Director for Home Health, and as my title implies, I was hired to transform home health. I've been in this role just over 2 years now, and even though we've been through some great strides with our transformation initiatives, including SCSP, our progress has definitely been impacted by the last 2 years with the pandemic and floods and wildfires. So I just want to take a minute right now and just let you all know that we really appreciate and recognize all the hard work that you are doing on the ground through all of the challenges we've had. And even as the SCSP work has advanced, all of you have taken this on and done your best to initiate and implement as you're able. So I just want to thank all of you. We see what you're doing and we appreciate the work you do with our clients. So thank you. So a little bit about me. My background is a registered nurse. I started my career in Penticton Regional Hospital as a med-surg nurse. I've worked various areas of acute, including I was an emerge nurse. I worked down on the Lower Mainland as well, and moved to Alberta in the early 2000s. And shortly after I moved to Alberta, I found home health in Alberta. And I have spent 15 years of my career as a case manager working what you call home care nursing, continuous nursing. I worked in suburban, I worked in rural, and I worked in the inner city. I worked on a palliative team. I've worked every sector of home health. I've worked it. So I do understand the work that you do. I was a frontline clinician, and then I was a team lead, and then I was a project lead, then I was a clinical operations manager in home health before moving back to Penticton 3 years ago. So I'm very grateful to be in this position because I see the work that needs to be done so we can get home health to where it needs to be. I lived and breathed a lot of the transformation in Alberta, and I will tell you, it is very challenging. It was tough at times, but from experience, I can tell you that it was after we got to certain parts, very gratifying. At the end of the day, as a frontline clinician, I would go home at the end of the day and just feel that I had made a difference for my clients. Because some of the transformation work, it involved a lot of efficiencies, making things work better, a lot of improved teamwork. Our caseloads became smaller, so we could spend more time developing that relational care management continuity with our clients, all of those pieces. So it is possible to get there, but there are a lot of pieces that need to happen for us to fully get to the end game. And I will explain a little bit more of that as I work through this presentation. So I'm hoping that after I present to you today, your questions of why are we doing this will be answered, and that you will trust the process, that the changes and the initiatives that are coming at you, there is an end game to all this, and it will make sense eventually, and will make your work easier, and you will hopefully at the end of the day go home and feel that you've made a difference in your clients' lives. Not that you don't already, but it's going to get better for you. So the first thing people always ask when there's change and work coming at them is what's in it for me? That's a natural thing that we all ask. We want to know what's in it for me. So obviously our clients are going to benefit from this transformation and some of the work we're trying to achieve with proactive, responsive home health services. But really, when you think about it, that this is not only for our clients, but it's for our family members, it's for our friends, it's for our neighbors. And just ask yourself, as a recipient of services in the future, wouldn't you want to remain independent in your home if you chose to do so, with the supports available to you in your own community? Wouldn't you want to avoid long-term care if you could, if you had the supports and the choice to do so? I think that's what we all want. We want to maintain our independence. And that is the overarching goal here. That is the transformation of home health. We want to basically put this in for our clients and our friends and our neighbors, but we want to do it for ourselves as well, because ultimately we'll all be end users of the system. So we are striving to create and provide sustainable, equitable, and cost-effective, um, cultural, appropriate, and quality home health and home support services, with the goal of honoring and supporting a person's choice to live in their home as long as possible. So that's what's in it for us. So I just want to go over a little bit about our team. Some of you are aware of who we are, but I think maybe some of you on the call may not be. So we were hired to transform home health, and we're a relatively small team. We have 4 practice leads. You might recognize some of the names on the screen, as well as 4 RKCs and my admin assistant. They work in dyads, and each one of them have their own portfolio that they're responsible for, with various projects and initiatives attached to them. They are the ones leading the work, with my assistance, obviously. So this is our overarching work plan for the transformation. So when we come up with initiatives and things that are presented to your teams, you might wonder where they came from. How did this come to be? So I just want to explain, this is what guides our team's practice. It is our role to ensure that everything we create, the tools, the standards, the standard work, the guidelines, align with Accreditation Canada standards for home health, as well as Ministry of Health policy. The ministry essentially is they're the ones that provide the overarching direction that we have to go, because they are employed by the voters of the province. So they are essentially our boss, and they are telling us what we need to do. So we take that policy, interpret it, make sure we apply accreditation standards, and most importantly, the evidence-based practice. We do the research behind it to make sure that it is in alignment with evidence-based practice. So all of these things that are coming at you align with these 3 things. That is the role of our team. So I just want to go into a little bit about the why. So why all the change? So as I've just explained to you, we have 3 things that guide our practice, but there is one big reason here for the SCSP initiatives, like the MRC and the CCCP. So we are doing this basically because of this policy instrument that was delivered to us by the Ministry of Health in November. And within this document, it has very specific instructions about things that we have to implement to be a fully complete SCSP. So we took that document and broke it down into all the little pieces of work that you are doing right now. So just on the next slide. So the foundation for all of the SCSP is essentially care management transformation. And if you think of a quilt, this is the quilt backing. Okay, this is what we ultimately want to do. And then all of these other little initiatives like MRC and CCCP, they are the quilt pieces that attach to this foundation. So when I talk about, or we talk about, or you might hear us talking about this proactive, the responsive service, that all clinicians will provide care management service, that we will provide relational and system level care management. It's all of these other quilt pieces that link into this that will get us to the full transformation we want to get to. So this is a real a change for IH, because traditionally IH has talked about care management belonging to continuous nursing. And I really want to start a shift in thinking here, because care management isn't just about completing RISE. That is one thing that a care manager will do, but there is much more to care management service that the client deserves to have receipt of. And so every clinician needs to have the competencies of care management and be able to deliver those services. And really, a lot of you are doing care management and you're not even really aware of it, or we're not calling it that. And I'm talking about home care nursing and allied health. So we need to shift. And part of that shift is standardizing our home health language, really calling things what they are, shifting from home care nursing and allied health to short-term care management services that may involve allied and nursing, and continuous care management that may involve allied and nursing. So this is part of the shift and change that is happening as part of the transformation. And you'll hear more about that in the coming months, years, because this is going to take a while to fully implement. So here are some of the other pieces that come out of the policy document that I showed to you, which I know you will recognize some of these names. So this is where all this come from. So when you hear us talking about all clinicians working to optimal scope of practice, that's right from the policy document. If it's within your scope of practice, you should be doing that for the client. An example would be a nurse in the home doing a RI. If they have a simple wound or a wound that can be addressed, that's within that nurse's scope of practice to look after that wound instead of doing a referral for another nurse to come into the home. Single point of access, all this work with central intake, that's where this come from, the policy document. And just bigger picture, eventually we're going to get to one big central intake for all of IH. It's going to take a few years to get to that, but these 7 central intakes are eventually going to merge into one. So wherever you live in IH, you'll call one number and you will get access to your home and community care services. Team-based care. And of course, the reach into acute. So I know this all looks familiar to you, but I just wanted to share that that's where all these pieces of work come from. We have many more initiatives that we're working on that I'll also share with you. So these actions, so what are we focusing on here? So 4 areas, and each graphic recognizes 4 big buckets. So the first one is we are attempting to align guidelines and practice standards, our education, our CDSTs, our home health language with the Ministry of Health, Accreditation Canada, and CIHI, which is the Canadian Institute of Health Information. So we want all of that to be in alignment so it makes sense to you and our end users of service. We want to standardize roles and responsibilities across home health. So no matter where you work in home health, that standard work, the standard way of doing things will be the same across IH. And we want all clinicians to work to that optimal scope of practice. We want to create gold standards and efficiencies for visit volumes for clinicians based on data. We want to do the same for scheduling and those client transition points. And as I just said, we want to increase the use of data. That's the 4th one, to improve workload organization and prioritization. And this is a huge thing for clinicians and your teams. So what we're looking at doing is using our actual data, which is captured from some of the initiatives we are asking you to implement on your teams, and pull that data to help inform decisions and prioritization of your work and workload. It will also help inform a business case for more FTE for home health, which is what we need. If we really truly want to get to that responsive, proactive place that we want to be, we do need more FTE, but we cannot ask for more FTE until we create efficiencies, we work effectively, we uncover all those rocks, we put in standard work and processes. We're basically, a lean, mean home health machine, but then we use the data that we've created with these tools to actually create a clear picture to our senior leaders and to the ministry as to where we're at and all of the busy work that we're doing and why we need more FTE in home health. So our new direction, what outcomes do we want to achieve? Well, these are the three big ones, obviously. For the home health client, we want them to know who their MRC is. They need to know who to contact. If you had services, wouldn't you want to know who's collaborating, advocating, coordinating your care? Yes, you would. You don't want all these different names. You want one person, one go-to. That client is going to feel connected to their care. So they're going to know what their care plan is. They're going to be aware of their CCCP and they're going to have input to it and they're going to have a copy of it, and their family too. The physician ultimately is going to have a copy. We see the CCCP becoming a one-stop shop for home health. We're meeting with MHSU to have them come on board. We see this really, the CCCP as you see it isn't the end version. It's morphing into something that is going to be quite incredible for home health. The current version is what we're using, but I just want you to be aware that we are working to tweak it to become an amazing one-stop shop for all of the healthcare sectors to see the work that we do in community. It's going to be a communication tool, but also an information tool. We want client independence. We want client satisfaction. We want to decrease caregiver burden. We want to improve response times. We want to improve clinical outcomes for our clients. We want those improved client transitions. We want improved system integration for our healthcare systems, the different sectors talking to each other, such as the reach into acute. We want decreased number of home health client emergency department visits. We want increased number of assessments for long-term care done in the community versus acute. We want delayed or prevented admissions to long-term care. We want to keep these people in their home environment if that's where they wish to be. We want to keep them in assisted living. We want to avoid long-term care because, ask yourself, isn't that what you would want? Isn't that what you would want for your family member or your friends? That is what we're trying to do here. We want to be responsive and proactive. We want to case find. So if, we have a referral and maybe that client might not be quite ready for home support out of the gate, what else could you do as a care manager to facilitate or assist the client with wherever they're at in their health journey to keep them at home? Being an active home health client isn't just about having home support services. There is so much more that you can do for that client. And I know this kind of goes against where we've been with home health and saying, you have to have home support to be on my caseload, but that's not true. There's so much we can do with care management to be proactive with clients' needs and family needs, and link them up with community resources that help support them living at home. We want to optimize the workforce. We want all of you guys to be working to your optimized state. We want you to feel supported. We want enhanced team-based care. We want to reduce administrative burden for all of you. We want the right person doing the right work. And if you haven't heard, it's coming out. It's a soft launch in EK April 1st and a full launch May 1st. All of those reassessments for TRRs and RARs for care managers are going to go to I was going to say clinics, not clinics, to clerks. So we are taking that administrative burden away from you, so you'll have more time to spend with your clients. These are the things that we're looking at to help improve your capacity to spend more time with the clients. So how are we going to do this? The next slide is very busy and I don't want to overwhelm you, but I just want to show you. This is some of the work we're doing. This is some of our current projects that are in progress or in the queue to begin. And there's much more in addition to this. This is kind of the high level stuff that we're working on. And if you look at the green bar in the middle, the MRC and the CCCP are actually connected to everything you see on this screen. If we do not have that 95% adoption across interior health, all of these other things that we are creating for your teams to work more effectively, work more efficiently, to make your job better, to have better client outcomes, will not be successful if we don't have that 95% adoption. And we leave a little bit of leeway there because we recognize when clients move from one health unit to another, or a clinician moves from one caseload to another, that there's a little bit of a transition period there. So that's what that 5% is. But we need that adoption percentage for MRC and CCCP right up there so we can provide to you a caseload measurement tool that is going to clearly highlight to you and your team members and to your leaders what your caseload looks like for complexity. This isn't about numbers, this is complexity. You're going to be able to look as a team who is red hot for the day and who is green for the day so you can support one another with your work and workload. We are going to create a clinician dashboard, and it's actually in the queue for our IMIT to build, because we've done a lot of that work, that is going to enable teams to look at the priority work that's coming up and allow you to organize your work and workload on a daily and weekly and monthly basis with this dashboard. It will be a game changer for your teams. So we're really excited to bring this stuff to you, but it won't be successful if we don't have an MRC attached to it. The other one is the reach into acute. It's on the CCCP. So if we don't have that implemented, we can't initiate that new process with acute care and the physicians to have access to our CCCP until it exists for our clients. So I'm just highlighting the importance of the MRC and the CCCP adoption so that we can bring some of this other exciting work to you. The next slide, I just want to share Nelson. They've done some amazing work there. They were the first area to get, they're at 94% right now. So they're almost at their target. And so I reached out to that team and the leadership there and the CICC and the team leads. I said, okay, what are you guys doing? How did you do this? And so they just shared some of the high level things that they did. And I just pulled some of the themes together on the slide here. I won't read them. You can see them here. But what I do have, the CICC that was instrumental in getting the team up to this adoption rate wrote a 1.5 page tips and tricks, what she did with her teams to help get the buy-in and get them to start implementing. And she's allowed me to share that with you, and I will share that after this presentation, along with some other resources to help you get your numbers up. So what we need from you, we need 3 things. We need your teams to fully adopt and implement MRC and CCCP for every single client that is attached to your area. We need you to ask questions and request support when barriers exist so we can help work through them. Reach out to your team leads, your managers, reach out to our team, break through those barriers. So we have a couple things that may help you with that. So the first one is this key message document on the right, which is essentially this presentation on a 1 page. I will give you a copy of this for you to share at your status assessment exchanges, to share at your team meetings, to help answer some questions. And my name's at the bottom. If you have any questions, please reach out to me, because we really need to land these fundamental foundational pieces of work so we can move forward for our full transformation of home health. Some other resources, we have 2 excellent pamphlets. These came out from the Patient Voices Network, and these are going to be on the CCCP toolkit, but I'm also going to electronically deliver them to your inbox after this meeting. The left one is for the client. The client's asking, why are you asking me these questions about what my goals are? What matters to me? Well, this brochure may help. And then on the right is a background resource for healthcare providers. And if you're wondering why are we asking these questions, that this is an excellent resource to help answer some of those questions. The other thing we have for you is a Q&A. I'm not sure if you're aware, every second Thursday, Brandy Antle chairs this meeting, and it is an opportunity for anybody to come in and ask whatever questions they have, but also to share your successes. We want the positives as well as your questions and your barriers. We want to help, we want to hear. So that is your opportunity. So if you need an invite, please reach out to Brandy and she'll send you an invite. So that is enough talking for me. I will stop now. Stop sharing my screen. So I'm just going to ask whoever's on the call, what do you think about what I had to say? Does anybody have any comments? Do you have any questions about anything I've had to say on the call? Does this resonate with you? Does this make sense to you? Is this new information?
Hi, it's Carrie, case manager. Can you hear me?
I can hear you. Yep.
Oh, perfect. Yeah, it's a great, there's some new stuff for me, so thank you very much. It was very well done. And also just the fact, like the one point that I think some of us are a little concerned about is the full scope of practice. Is there a plan, an overarching plan for some of us who haven't done any hands-on nursing skills for many years, that's part of that whole thing, or how's that looking?
Yeah, and it's optimal scope of practice, not full scope. So we want to get to the optimum scope of practice, which makes sense with where your teams are at for capacity and learning and education. We have a couple things in the queue. So there is an overarching wound care strategy. Just as an example, I've met with that team. It's a 3-year plan, and within that strategy, it does have all nurses working to full scope of practice. So we're looking for, you know, because the person in the home that's asking all the questions, for example, doing a RI, has put in home supports for the client, really does know the client, the family best. They should be doing that simple wound care or that wound care for the client because they know all the other pieces of information. And it doesn't make sense to have another nurse come to the home. So I hear what you're saying. So the answer to your question is yes, this isn't going to happen overnight. And I don't want you to panic. We would never, ever say this is happening now. There's a lot of work that has to be done, but I also want you to know we recognize the capacity of your teams right now, also the current structure of your teams. It's going to take a lot of work to get to where we need to go. So nothing's going to happen overnight, and I don't want you to panic. I was part of this work in Alberta, and I want to assure you, I understand what your concern is, but nothing will happen until you feel competent and ready to do the work. It'll take a lot of education and a lot of stakeholder engagement to get us to where we want to go. The first piece, though, that we're working on right now as far as optimal scope of practice, and you probably heard it in my presentation, is around care management. It's that shift in thinking that only continuous nurses do care management. That is so wrong on so many levels. That is not it. And as I already said, many of you, even home care nurses, LPNs, even allied, you are doing care management. You're just not calling it care management. So I want you to stop thinking about that only care managers do RISE, because that's not true. That is not true. They do much more than that. So there are many competencies to become competent in care management that we have developed a new education pathway that we are trialing up in Kamloops. And as we move that along, all new clinicians coming into home health are going to have care management education as part of their uh, orientation package. So that'll start the shift. The other thing that's going to start the shift with care management is changing what we call things. We're going to move away from calling it home care nursing and continuous nursing. It's going to be called short-term care management and continuous care management. And you'll either be a short-term care manager who offers nursing services or a short-term care manager who offers allied services. Yeah, like that. So that's going to start some of the shift. So I hope I answered your question. I kind of went on there, but I I hear what you're
No,
saying.
that's perfect. That's perfect. Thanks so much. I am reassured to a certain degree, so thank you. It'll be great eventually.
Yeah, we're working on some exciting stuff I can share, like short-term acute client assessments. So these ones and dones, these clients that need 1 or 2 visits and they're done, working on a short-term documentation that it's going to be easy peasy for you guys to do. None of this 2-3 hours to admit a client. Like, I'm so excited to bring that stuff to you. And that's some of the stuff on our work plan. Like, I'm looking for anything where we can give you guys back some capacity to spend more time with your clients and reduce that administrative burden.
Great.
But
Perfect. Great. Thanks so much.
you're welcome. Does anybody else have any questions or comments? Ask me any question you have. I want to hear them.
I have a question and a comment. I have a comment about I feel like in community we are super efficient. We have worked with Les for years and years and years. And I feel like now there needs to be that infusion of FTE that we have not had for as long as I've been in home and community care, for like 12 to 20 years. So we just haven't had that infusion. We've done more with less constantly. And now there's a lot of promises about providing better service, having more capacity, but we just don't have the bodies to do that. We are constantly putting out fires because that is what we have time to do. We're constantly doing more education with nothing being taken away, more administration tasks with no assistance for those. So I would love to work full scope as a therapist, but I feel like with doing more and more care management, we just have less time to do rehab, which is what we are trained to do. So I love the fact that you're wanting us to do more full scope or optimal scope, but we definitely need an infusion in people, because without the people, as we've seen with CHWs, we cannot help people to the level that they need help to stay out of long-term care, stay out of acute care, without bodies to actually do the work. So it's challenging for us because we would love to keep everybody out of long-term care, but we just don't have 24-hour community health workers. We can't even get health workers to get started for someone who lives with a family member. So that is the frustrating piece, because it's like a hospital working with 50% of the nurses. They just can't function. And right now that's where we are at in home health. So it would be lovely if we could get some more workers to do the actual work.
I totally 100% agree with you. It blows me away that IH hasn't been the recipient of some more funds for community, right? Like I see it. You guys you did exactly what you said. You're being asked to do more with no more resources. So what I wanted to, I kind of alluded to it in my presentation, but I want to explain this to you. So anytime we get money, it comes from the ministry. Before you get any money from the ministry, you have to explain why you need it. They don't want to hear because we need it, because we're busy, because we're being asked to do more with less or whatever. You know, they want to see data. They want to see evidence that we are busy. Currently in IH, we cannot clearly articulate how busy we are. We cannot clearly explain how complex our caseloads are. All we have is numbers. And as you all know, a number is just one thing. First thing you need is a clean caseload. Those numbers got to be accurate. That client should be on there. But there's so many factors that affect that caseload and how busy it is. So what I'm going with this is, we need a way to accurately measure the complexity and explain and measure the complexity of the work we do, and show that we cannot meet this because this is what we're doing now. So in order to get from here to here, we need this. And without data, we can't do that. So this caseload measurement tool that I'm talking about, this clinician dashboard that I'm talking about, that is going to give us the meat that we can put together a business case. So we can say, this is where we're at. This is what our caseloads, these are our clients. We're going to pull RUG scores from your accurate RI assessments for long-term. We are currently working on a way to pull data from our short-term clients, both allied and home care nursing, so we can measure the work, and we're taking in all these different factors so that we can highlight a business case to the ministry of how we need more FTE. Can somebody please mute if you're not speaking, because I'm hearing a lot of background.
So I totally appreciate that. I think those standardized caseload assessments and measures will be great. We've been tracking our own data for 5 years, and we see our numbers going up and away without any, coverage for vacations, sick time, ULOAs. So we actually are having less FTE because of all of those other issues, and not able to actually fill what we have sometimes. Like, I think there needs to be some partnership with government and education facilities to be training more people too. So I don't know if you have any comments on that, Susan.
Oh, I do. I think it needs to start with the universities. They need to do more education at that level, especially around care planning. Oh my gosh, care planning in every discipline, right? And yes, and the care management piece. When I was in Alberta, I was linked into the U of A, and I was part of a member developing their curriculum for weaving in care management into all of, not just nurses, for all of Allied as well. So this does work, like to have all clinicians doing care management. And you know, you are doing care management. You're just not really calling it that. And it's a real shift in thinking that it's, I mean, there are other pieces to it. For example, if Allied were to do a RI, yes, that's more work. It is absolutely more work. And I'm not saying we're going that way right now, but eventually we will. But you know, you need more capacity. We were really low on Allied too. I totally recognize that when I pulled the data. So what I'm trying to say is we can't use subjective data. We need objective data that's pulled from assessments to clearly articulate how busy we are. We need to paint a picture about the complexity of clients that we're caring for. And it's not just about numbers and visits. It's about the quality of the visit as well. Like if we're going to do, you know, really dig in and spend more time with our clients, it's going to be measured in the length of the visit as well. It's not just about counting, check, one visit done, dropped off supplies, one visit done for our volumes for ministry reporting. It's more about the quality and the complexity of our caseloads and painting that clear picture. Because I know you guys are going full out. I know you are working to full capacity. You know, I know there is some room for more efficiencies, especially around decreasing that administrative burden. I know that for sure. We've uncovered it. I've shared some of the stuff, and the IRS, the financial reassessments, is coming to you guys, so that'll give you some capacity back for the ones that do the reassessments, the nurses right now. So yeah, but I hear what you're saying, and I totally agree. We need more FTE. So when this happened in Alberta, after the business case was developed, guess what? They pulled $55 million from acute in the Edmonton zone and gave it to home health. And you know what they did? They created a whole bunch of case manager positions and case manager practice lead positions. And do you know what happened? The ED visits and the length of stay in hospitals went right down because they pulled the money over and put it so we could do that proactive work that we really want to do in community. So I've lived this. It works. I had a caseload of 45. I could really, and I had short-term and long-term clients and palliative clients on that caseload. I had all types, and I knew exactly how busy it was because it was measured. So anyways, I hope that helps. I keep talking. I can talk about this stuff all day long, but I want you guys to be reassured that, you know, I understand what you need. I hope I'm articulating that to you, and we're working really hard to try and get us to where we need to be. There are a lot of pieces that need to be worked on first, though, and this isn't going to happen overnight.
I had a question regarding the financial component that you touched on. What would that look like in the future?
The reassessments, you mean?
Just in general for case management?
So as of May 1st, so it's happening in EK right now, April 1st, May 1st, all of IH, care managers will no longer have to do reassessments, temporary rate reductions, and the RARs, retroactive, and the temporary rate reductions, that is being taken away. Clerks are going to be doing it. Education sessions are coming out shortly. We're doing a soft launch in EK first, and it's IH-wide May 1st. I'm very excited about that.
So I have a question. How does a clerk do an assessment?
You know what? That's an education session, and you're going to get it. That's a whole session in itself. There's a bunch of process changes we had to work through. So they're not doing the initial assessment. Case managers still have to do the initial. Okay. It's the reassessments and the retroactive stuff. So there's a whole new process for that, and you will all be receiving that education and training in the coming weeks. I don't have time to really go through it in detail.
This is Sherry Mitchell. I'm an occupational therapist in the community. My one concern is I'm feeling, I understand where you're coming from, and you're talking about how we have to prove our caseload, time efficiency and quality of care and quantity that we experience. the problem I foresee right now is that we have really high stress with all these addition of paperwork and educational sessions. And I understand it's for the greater good, but it doesn't really mitigate the stress levels and the reduced number of people we have in our current system. So that's my concern, is that maybe in a year or two, this is going to mitigate, but right now, we're not really addressing that stress load. And I have to be honest, the beat in overall and community care or health is not at its highest.
Mm-hmm. Oh, I get it. Our goal is not to create more work, is to take work away and make things work more efficiently. Like, that's our goal. Unfortunately, IH is quite challenging because it's so big and we have such different things happen across all the geo areas. So we're attempting to get us all on the same path. And I have to bring us back here. I hear what you're saying, but this is ministry policy. This isn't going away. We don't have an option here. This is our boss essentially telling us we have to implement this. Otherwise, if we don't, they take money away from us. So we have to figure out how to do this effectively, efficiently with what we have. But I want you to know that I have your back in that. If you trust us in that, do the work that we're, the MRC and the CCCP, we will work on the stuff in the background that will help create a visual of what the work is, so that we can essentially create a business case to get more FTE. Like, it's like the cart before the horse. We can't get the cart before the horse. So we have to land the foundational pieces so that the other ones work, so that we can get to where we need to go. So yeah, and I hear what you're saying, and I know you're doing the best that you can. And sometimes, it's difficult for me to dig into little nuances in teams because it's so different, like across IH. So we're trying to create standard tools that will work with our current state, but we do realize there are little nuances, like COK is, totally different than anywhere else with the volume and the people and everything in your teams and the structure, right? So yeah, I guess I just need to reemphasize that I hear what you're saying, but we have to figure this out. And if it's not working, you need to talk to your leaders. You need to, talk to our team. We need to help you figure this out so we can get this work done. I hope I'm explaining that. I wish I had a magic wand and I could just give $55 million right now, but I can't. I have to do the work first, as do you guys. And we have to create the tools that will give us the information we need to move forward.
Excellent, thank you. And I understand that process. It's just we are losing a lot of staff right now, so it's just a hard place, and which means we're also going to spend more time on documentation and staff. So it is difficult. But thank you.
Well, I explained the stacks that we're working on right now. That should decrease the amount of time documenting for short-term acute clients. I think Allied Health will really benefit with that. We're looking at developing basically an MRC care manager assessment that will pull, when the MRC documents in there, it'll automatically pull to your Allied assessments. We're actually looking at Allied assessments because your assessments are like great. I love them. So we're looking at how we can automatically pull that data so you don't have to double chart. One of the unfortunate things is our IMIT department, a lot of our work is dependent upon them, and they are only so big as well. We need to triple the size of our IMIT department in IH because everything's moving electronic, and so that is one of our issues with our work capacity of different teams that are dependent upon. So I hope I've explained, though, that the MRC and the CCCP are foundational pieces, initiatives, and all this other stuff that I'm talking about will not work. It won't be successful without MRC and CCCP. So I really need you to work with your teams to figure out how to do this. I'm going to give you some resources. Reach out to us, reach out to your leaders. Let us hear your barriers. Like you can't name the MRC as the clinic nurse. Clinic nurse 7, because first of all, that doesn't follow a ministry policy. That's totally against ministry policy. We can't do that. And it's not best practice. It's all in the literature. It's not best practice. The client deserves to know who their MRC is. And if you say, well, how do we do that in COK? Well, that's what you have to figure out. How can we make this work? We're being told we have to do it. So what do we need to do on our teams to make this work? One of the things they did in Alberta is they combined FTEs to kind of share a caseload. So, and then they changed rotations so that always an MRC was there every day with this group of clients. So you got to kind of get, you know, creative to figure out how can we meet this goal. Just sharing some of the high level stuff that I know. I got lots of ideas, but it comes down to your teams highlighting, okay, we can't do this because what's the barrier? Talking to your leaders. Okay, here's the barrier. What can we do? We have to get here. This isn't going away. This is not optional. It's happening. We have targets to meet. And as I said, if we don't meet targets with the ministry, they've given us money to do something. We don't meet the targets. They review it. They take money away. So that's the way it works. They're essentially our paycheck, right?
Susan, has there been any discussion about for short-term clients not having to do full MRC and CCCP or having some kind of short-term streamlined assessment? Because even for the clients to provide all their goals, or if they may only have one goal with a short-term involvement with us, it's hard for us to get all of the paperwork done if they're only on care for 2 weeks.
So as I explained to you, I called it a stack. Short-term acute client, a stack assessment. So we are working on, it's on our work plan, a project that will, those clients that are on for less than 2 weeks, you will have to implement. We've already met with PPO, they're on board, professional practice office, to implement a short-term assessment, which is going to be so easy for you guys to implement and, you know, initiate and discharge the client. So that's one piece that we're doing. But you have to assign yourself as MRC, okay? That doesn't go away. That's ministry policy. Even if the client's on for 3 days, they deserve to know who their clinician is. That's number one. And it isn't an assessment, even though it's listed as a PCS point of care. It isn't an assessment. It's a task. And ultimately, I want admin to do that. I want admin to be able to assign MRCs to caseloads, but our current system does not allow that. So that's why we have it the way we have. The CCCP isn't going away. Every client, it is ministry policy, it is accreditation standard, it's not going away. We have to do it. Now, as I said, the CCCP is evolving. What we have is currently, there are some updates that are going to make it better. They're in the queue right now that's going to actually make it better. But if they only have one goal, you only have to put one goal on the CCCP. You don't have to do 7 goals. Like, there's only 4 or 5 mandatory fields in the CCCP. You don't have to do the whole thing when you initiate it. If the client is only on for a couple of weeks and it's a, you know, quick and dirty, you know, they need a walker for a short term after following their hip or whatever, like that will be a stack assessment and just easy peasy CCCP. So I'm not sure if, you know, if you have any questions about that, please reach out to Jody Alluri, who's the practice lead, and Heather Busby, the RKC, to help. We attempt to explain that in our education, but sometimes I think there's some misconceptions about the CCCP, but it ultimately is going to become our one-stop shop. I think I see it. It's really where you're going to go in. I see it almost as like having, like it's the MRC main assessment, where all the interdisciplinary team comes on board and we interact as a team, and even having an MRC discharge assessment attached to it. This assessment is ultimately going to show in the EMR. We want primary care. We want physicians to see it. With the reach in, we are going to show acute how to access the CCCP so they can see what home support, what services they have, and what inter-D. So the OT and acute is going to see what the OT and community was doing. It's all going to be right there. So it's morphing. It's not perfect, not even close, but it will get better. But the CCP isn't going anywhere, and either is the MRC.
So Susan, just to clarify on your point there, I mean, am I hearing then that the future state here would be the stack assessment CCCP would actually be replacing our output of assessments for allied health? I mean, how does that align with, our college requirements that, that because our clinical templates right now are designed with that in mind specifically. So are you saying then that the stack assessment when it comes to fruition of the CCCP would actually be college, essentially allied health college compliant?
So this is British Columbia is definitely different than Alberta, because this was a new thing I learned when I came here with your college requirements, because it's totally different in Alberta. So what we're attempting to do is look at your assessments and see how what's entered in the stack will, because your college requirements aren't going away. I have no control over that. You guys have to do as per your college regulatory requirements. But what I'm saying is, if we have the stack assessment, what you enter will filter through into your allied assessment. So when you go to do yours, what you've entered on the stack will actually be over there. So just know we are talking to allied leaders about Mandy Kennedy, about how this works, and Darlene Russell's on my team as well, to make sure that we meet those college requirements. But we're always looking at ways that we're not duplicating charting. But this is also for on the nursing side as well. They don't have the same deal as you guys, but I am acutely aware that your documentation standards are different, and there are requirements there. So we're doing our best not to duplicate. I hope I answered that for you.
You did. But I mean, the thing I think the opportunity here would be if the stack actually kind of has the components that's required as per our college, then as an organization, it would be a shift towards where home and community allied health would just require to have a stack, and that would, as long as it's compliant with college requirements, then that's it.
That's right. The thing is, those stacks are really, they're quick. There isn't a lot of meat on them because they're for those short-term clients, i.e. a person who's had a tupper, a transurethral prostate resection, they got a catheter in, we go to see them, we pull out the catheter, they're done. They pee, they're done. That's a stack, right?
Oh, okay.
You see,
well,
or you need to go out and give the clients some equipment following their hip surgery. That in Alberta, that's a stack.
But I wonder, rather than pushing or pulling the information from the stack to our assessment, if there's an opportunity to kind of integrate, integrate it into the stack to where it could actually balloon up to a full allied health template by just kind of clicking certain things, right? Or, it just kind of stays simple if it's not an allied health assessment. I've seen some iterations of clinical templates that does actually do that. So I know Meditech has that capacity to do so, but it's just a matter of, putting it forward. In other words, redesigning this whole documentation template to have two functions, right?
Yeah.
It's a short form for the stack, like you mentioned, in an allied health clinical template.
So what we're doing right now, we're pulling all the allied assessments, we're pulling the nursing assessments, we're comparing them, and we're cross-referencing them. We're trying to pull out what is the same on all of them to have one MRC assessment, and all the stuff that's the same automatically feeds into the allied. We see the nursing one going away totally, and it just being this, because we can do that with nursing, we can't with allied. But I hear what you're saying, and we are looking at that. I mean, that would be great if we could do that, but it's a big, it's connected to the college and the professional practice office, and so obviously all of that, lots of consideration, lots of discussions have to happen to see if that's possible. But yeah, any way we can create efficiencies and make it intuitive, that would be the end goal.
Yeah, thank you.
You're welcome. I love these conversations. And just so you know, I want to come to your offices. I want to meet some of you in person. I want to hear, I'm planning to do that in May, to come up to COK. And if you see me, please come up to me and have those conversations with me. Home health is very dear to me. I all my research, my graduate studies were all about home health, and I really want to get this right in IH. Because ultimately I'm going to need the services. So I really want to get it right. And I want to help you guys do this. I want to hear your challenges. I want to gain your trust. I want to answer your questions so that we can work together and build this momentum and get it to where it needs to be. Get that FTE. Like, if you want us to do this right, you know, show us the money. Like, we need to, but we got to show them that we got to, like I said, we have to paint that picture with data so that they understand the work that we do. I got your back, so I'm trying to do this for you guys. So yeah, I hope this presentation has tweaked your interest, maybe hit a few points and aha moments in your head, and you know, I hope that we can move the MRC and the CCCP along, because we really want to get to these other tools for reasons I've already explained on this presentation. I hope that makes sense. And if any questions come to you after this presentation, please feel free to reach out to me and my team.
So, sorry, just one last question. Is there still opportunity to kind of provide feedback for the tools for improving its efficiency as we're kind of using it? I mean,
Absolutely. Absolutely. So you can either come to the Q&A or you can reach out to the practice lead that's attached to the work via email and just make some suggestions. Because we're always, like the CCCP, as I said, it's got a lot of work that needs to be done on it. We're dependent upon IMIT to make those changes. It is morphing, as I said, but yes, anything you guys have, any suggestions, please put them forward to the practice lead and or RKC attached to the work so that we can talk about them as a team. Okay. Brandy, do you have anything to add? We got 2 minutes. I look forward to seeing you too, Carrie.
Sorry, Susan, I was on mute. No, I'm available. If anybody knows who, most people know who I am, so just reach out if you have any questions or comments.
I'm just looking in the chat box there. I think I answered everything. Hey, not a paper. We always use lean, looking at that, and that stack assessment is going to help with that. The short-term clients, but yes, I know I am hearing how long it's taking you, and that's crazy making. So, you know, we have a lot of items on my work plan. If you ever want to know about any of the other initiatives, when you see me, please ask and I'll share them with you. And I'm always looking for input of any other ideas that you guys have that might help.
this might be a suggestion to kind of help inform people doing the work and kind of allay some apprehension. It's great to hear the big vision as well as the plans that are kind of in place. I wonder if there's an opportunity to kind of have the work plan visible, kind of like on a electronic bulletin board, like you know, a team sites maybe that you have, and then you know that we could kind of see where we're at and what progress our progress towards just the overall picture, right?
So I would say absolutely. The only thing is our work plan are dependent upon a couple of things: digital health, IMIT, your capacity, wildfires, floods, this, that. And so the work plan's constantly changing based on what's coming at us. But with that said, the future big rocks, as they call them, for 2022-23 were shared with the directors. They have access to the team site that holds the rocks that we will update on a regular basis. So Brandy's also in the know about things, and it's not like I don't want to share, but I hesitate to share you a document that could change. So I don't know if it's helpful that maybe I come on the Q&A call, or maybe we have a meeting every 3 months where if you want to see where we're at with our work plan and I do a quick presentation to show you where things are at, like that could be something I could do with all of you.
Yeah, I
Maybe.
think that would be helpful. Yeah.
Yeah, maybe that's the answer.
Just to kind of you know, make a connection to see that the stuff that we're doing is actually incrementally helping push things along.
Yep. Yeah, we'll make note of that, Brandy.
Yeah, will do, Susan.
Okay, well, it's lunchtime, guys. You need your break. I want to thank you. Nice to virtually meet everybody on the call, and I look forward to meeting you in person. If you see me, please feel free to come up and ask questions, and introduce yourself now that we can do this in person, finally. And thank you again for all the work that you do. Bye, everybody.